Imagine trying to negotiate with someone who doesn't speak your language.
Good luck with that.
Right. And they think you're trying to poison them.
Yeah.
And they will violently fight you if you come anywhere near them.
Sounds terrifying.
Now imagine that person is like 2 feet tall, and it is your actual job to save their life. Welcome to pediatric nursing.
It really is a profound shift from adult care. I mean, with adults, medical care is usually this rational transaction,
Yeah, you explain a procedure, they want to get better, they cooperate.
Exactly. But you walk into a pediatric ward and, well, survival instincts have completely overridden any kind of rational thought. To a toddler, you are simply a threat.
Which brings us to our mission for this deep dive.
Yeah.
If you're listening to this, you're likely gearing up for your ATI RN Pediatric Nursing Proctored exam.
The big one.
The big one. So consider this your ultimate study companion. We're pulling the core concepts from the textbook, specific considerations of nursing care of children, specifically chapters 8 through 11.
And we are distilling the absolute most crucial nuggets you need to pass.
We're tracking the whole journey of a pediatric patient, starting with the physical battle of administering medications, then escalating to managing severe pain in a patient who can't speak, dissecting the psychological trauma of hospitalization, and finally, navigating the heaviest reality of all, which is end-of-life care.
And the foundational belief you really need to lock in before exam day is that passing isn't just about memorizing facts.
Right.
Yeah.
Or just memorizing medication dosages.
Yeah, it's about understanding the underlying mechanisms, like the why behind pediatric protocols. Children are not miniature adults.
They really aren't.
Their anatomy is different, their nervous systems are different, and their cognitive processing is just entirely different. Caring for them requires a completely separate toolkit.
Okay, so let's unpack that toolkit starting with chapter 8. The most basic intervention, right? Giving a medication.
Sounds simple.
It sounds simple. Because giving a pill to an adult takes like 5 seconds.
Yeah.
But giving oral medication to an infant feels like trying to defuse a bomb. So how are nurses supposed to physically manage a patient who is actively trying to spit the medicine right back out?
Well, you have to physically manage their anatomy, and that starts with positioning.
Okay.
The overwhelming preference for pediatrics is the oral route, just because it's the least invasive. So for infants, you hold them in a semi-reclining position.
Kind of like you're feeding them?
Exactly like feeding. But you never squirt medication directly down the back of the throat.
Because they'll choke.
Right. You'll trigger the gag reflex and risk aspiration. So you administer it slowly into the side of the mouth, the buccal cavity.
And there's this very specific mechanical trick the text mentions for infants who just refuse to swallow. You don't just wade them out.
No, you stroke the infant's chin while holding their cheeks together.
Wait, you literally hold their cheeks together?
Yeah, it sounds intense, but that physical manipulation actually triggers an involuntary swallowing reflex.
Oh.
By holding the cheeks, you're preventing them from using their tongue to thrust the liquid back out. And then the chin stroke stimulates the throat muscles to initiate a swallow.
So it relies on their native reflexes, not their cooperation.
Exactly.
I mean, I've seen parents try to bypass this whole fight by just mixing the medicine into a full bottle of formula.
Oh, yeah. You see that a lot at home.
But the text explicitly warns against doing that in a clinical setting.
Because it creates two massive clinical risks. First, dose control. Say you mix a crucial antibiotic into an 8-ounce bottle.
Okay.
And the infant falls asleep after drinking like 4 ounces. You have absolutely no idea what dose they actually received.
You can't document that.
You can't. And the second risk is taste aversion. If the medicine makes the formula taste bitter, the infant might associate that terrible taste with their primary food source.
And then they just refuse to eat altogether.
Right, which leads to dehydration.
So if you absolutely have to mix it to get it down, you use a tiny amount of a sweet, non-essential food, like a spoonful of applesauce.
Or sherbet. And you always measure the dose with a calibrated oral syringe. Never a household teaspoon.
Because household spoons vary wildly in volume.
Precision is everything in pediatric pharmacology.
Well, speaking of precision, let's talk about aortic medications, ear drops. Because I guarantee this will be an exam question.
Oh, absolutely.
Or always trips people up. There are 2 different ways to pull the ear depending on the child's age, and I always mix up the rule.
That distinction hinges entirely on cranial development. An infant's ear canal isn't just smaller, it's anatomically different. It's more horizontal and cartilaginous.
Okay.
If you just drop the medicine in, it'll just pool on the sides. It'll never reach the tympanic membrane.
So what do you do?
For a child under 3 years old, you pull the pin at the outer ear downward and straight back. This physically straightens that horizontal curve.
Okay, downward and straight back for a newborn.
Right. And as the skull grows over those first 3 years, the angle of the ear canal shifts dramatically. It angles more downward.
Oh, I see.
So for a child over 3 years old, you pull the pinna upward and back to straighten the newly shifted canal.
Upward and back for over 3. Visualizing the skull growing actually makes that so much easier to remember.
It's all about visualizing the anatomy.
But, stroking a baby's cheek or pulling their ear, that only works for oral and aortic routes. What happens when a child is vomiting or unconscious or they need a vaccine?
We'll lose those breaths entirely.
We have to bypass the digestive tract, which means introducing needles. And where are we safely putting an intramuscular injection in an infant? They don't exactly have massive deltoids.
They really don't. A tiny infant has almost no muscle mass in their arms. This is why the vastus lateralis, that large muscle on the outer anterior thigh, is the universal recommendation for IM injections in infants.
Because the biggest muscle they have.
It's the most developed muscle mass they possess, yeah. It can safely absorb the fluid volume without the needle striking the sciatic nerve or major blood vessels.
Which would be a huge risk if you use the glutes.
Massive risk. You don't use the gluteal muscles until the child has been walking for at least a year.
Got it. But look, getting poked with a needle is objectively traumatizing. Which brings us to a concept that completely defines modern pediatric nursing, which is atraumatic care.
Yes.
It feels like a total paradigm shift from the old days of just, holding a kid down and getting it over with.
Atraumatic care is a fundamental philosophy.
Yeah.
But it translates into very concrete clinical interventions. The medical model now actively prioritizes emotional safety right alongside physical safety.
The goal is to eliminate or at least minimize the distress using every tool we have.
Exactly. What's fascinating here is how preemptive it is.
The text gives some brilliant examples of this, like applying a topical anesthetic, lidocaine and prilocaine cream, often called EMLA cream. You apply that to the injection site a full 60 minutes before a puncture.
Right. You're actively blocking the pain receptors at the skin level ahead of time, so the child doesn't associate the nurse's touch with sudden agony.
It also dictates how we manage the environment, right? You keep medical equipment completely out of sight until the last possible second.
Yeah, you do not let a toddler stare at a syringe for 10 minutes while you prep the room.
That's just cruel.
It really is. And you allow parents to hold the child during the procedure using therapeutic hugging. It provides comfort while keeping the limbs safe and still.
And for infants, I found this really interesting. The text recommends offering a sucrose pacifier before, during, and after a painful procedure.
The sugar water.
Yeah. I always wondered why sugar water was treated like an actual medical intervention.
The mechanism there is fascinating. The concentrated sucrose actually activates endogenous opioids in the infant's brain.
Wait, really?
Yeah. And when combined with non-nutritive the physical act of sucking on the pacifier, it provides a mild, completely natural analgesia. It literally blunts their perception of the pain.
Okay, that's incredible. But, we can give sucrose pacifiers and EMLA cream all day. Medical care still inherently involves pain.
Absolutely. Moving into Chapter 9 here.
All right, Chapter 9, pain management. Because a post-op incision hurts, a bone fracture hurts. If I walk into a room and my patient is a pre-verbal 2-year-old who is just screaming, how do I objectively know if their pain is a 2 or an 8?
Assessing an uncommunicative patient is one of the hardest clinical skills to master. Because you can't rely on self-reporting.
You can't just ask them.
No, you have to become a forensic observer of behavioral and physiological cues. You need a tool to turn that subjective crying into objective clinical data.
Let's break down those specific assessment scales, because the exam tests heavily on matching the right tool to the developmental age.
Yes, very important.
Let's start with infants and toddlers.
So for patients from 2 months up to 7 years old, we rely on the FLACC scale, FLACC.
Which stands for face, legs, activity, cry, and consolability.
Right. You observe the child and score each of those categories from 0 to 2.
So for face, a 0 would be a totally relaxed expression. But a 2 is like a constant frown, a clenched jaw, or a quivering chin.
Exactly. And you combine that with their legs. Are they relaxed or are they drawn up in extreme tension?
And consolability, can you distract them? Or are they completely inconsolable even when the parent is rocking them?
You add all those numbers up for an objective pain score out of 10?
The text also calls out some very specific physical manifestations of pain in young infants. It isn't just standard crying.
No, an infant in severe pain will let out a really harsh, loud cry. Their entire body will be rigid or actively thrashing.
And their face does something specific, right?
Yes, their eyebrows will be lowered and drawn rigidly together, and their mouth will pull open in a distinct, squarish shape.
A squarish mouth. Recognizing that is vital because an infant obviously cannot point to where it hurts.
Right. Now, once a child reaches about 3 years of age, assuming normal cognitive development, we introduce the FACES scale.
That's the one with the drawings, right?
Yeah, the diagram with 6 illustrated faces. It ranges from a smiling face for no hurt, all the way to a crying, grimacing face for hurt's worst. The child can visually match their internal feeling to that external image.
And then, around 5 years old and up,
Yeah.
kids begin to conceptualize numbers and sequence, so that's when we can transition to the standard numeric scale from 0 to 10.
Exactly. And once you've objectively scored the pain, you move to pharmacological management. The WHO recommends a strict 2-step approach for kids over 3 months.
Okay, 2 steps.
Step 1, for mild pain, is a non-opioid, typically an NSAID like ibuprofen. Step 2, for moderate or severe pain, is a strong opioid, and morphine is the gold standard in pediatrics.
Okay, here is where I need to push back.
Oh.
Because I found what looks like a massive contradiction in the text.
Let's hear it.
I was reading the section on strong opioids, and it explicitly states that IM injections and intramuscular injections are not recommended for pain control in children. But we literally just spent the entire first segment talking about using the vastus lateralis for IM injections. Why are we suddenly abandoning that route when the child is in pain?
I know, it looks like a contradiction. But think about the principle of atraumatic care we just discussed.
Okay.
Think about the mechanism. Pain medication, especially for a post-op patient, needs to be given frequently, sometimes every few hours.
Right.
If you use the IM route, you are actively inflicting acute pain, driving a needle deep into muscle tissue every single time you try to treat their existing pain.
Oh, it creates a horrific cycle.
Exactly. The child learns that telling the nurse they hurt results in getting stabbed in the leg.
That's awful. So atraumatic care dictates using the least traumatic route possible for repeated interventions.
Precisely. Therefore, for severe pain, the alternative is the intravenous route. 4 medications provide rapid, steady blood levels without the repeated trauma of an injection.
Makes total sense.
And there's another crucial clinical point here. For continuous, severe pain, IV opioids should be administered on a strict schedule, not PRN, which means as needed.
Wait, why not just wait until they need it? Isn't that safer?
Because if you wait for the child to show severe signs of pain before giving the medication, you are chasing the pain after it's already out of control.
You're behind the curve.
Right.
Okay.
It takes much longer to bring their pain level back down, and it actually requires higher overall doses. By scheduling the medication around the clock, you maintain a steady state of analgesia. You stay ahead of those pain peaks.
And there's a long-term physiological consequence to letting them suffer.
A profound one. Untreated acute pain in early childhood doesn't just go away. It can actually permanently alter their developing neural pathways.
Wow.
It predisposes them to hyperalgesia and increased sensitivity to pain and chronic pain syndromes later in life. Their nervous system literally gets wired to overreact to stimuli.
So we manage the physical pain aggressively. We use scheduled 40 meds. We pair it with non-pharmacological methods like swaddling or kangaroo care.
That vital skin-to-skin contact with the parent that regulates the infant's heart rate?
Right. But physical pain is just one layer. If we step back and look at the whole picture, Chapter 10 really digs into this. The hospital environment itself is entirely alien.
It really is.
It's full of strange noises, strangers poking you, massive disruption of routine. A hospital stay is fundamentally traumatizing to a developing mind.
The psychological fallout is immense, and the most universal reaction, particularly in infants and toddlers, is severe separation anxiety.
Which the textbook categorizes into 3 distinct, highly predictable stages. Every pediatric nurse has to recognize these.
The first stage is protest. This is the obvious one.
Loud screaming, physically clinging to parents, active aggression towards strangers.
Yeah, it's the child using every tool they have to fight the separation. Then the second stage is despair.
And this is the clinical trap, isn't it?
Oh, absolutely.
It's so easy for a busy nurse to walk by a quiet room and think, oh good, the toddler who was screaming an hour ago has finally settled down. But clinically, that child is actually deteriorating psychologically.
That is the exact danger. The silence of the despair stage is not compliance. It's not comfort. It is pure exhaustion and hopelessness.
They just give up.
They do. The child withdraws, becomes severely depressed, stops communicating, and frequently exhibits developmental regression.
Like what?
Like a newly potty-trained toddler will suddenly start wetting the bed, or a child who is speaking in full sentences will revert to babbling. They are shutting down.
And then comes the third stage, which is detachment. And this is arguably the most heartbreaking one.
Because on the surface, it looks like a recovery.
Right. The child appears happy again. They start interacting with the nursing staff, playing with toys, forming new relationships.
But the textbook emphasizes that this is a profound psychological defense mechanism. They are emotionally detaching from their primary caregivers, their parents, to avoid the unbearable pain of separation.
Understanding these stages is critical because you have to realize that a child's entire understanding of their illness is dictated by their developmental stage.
Yes, let's break those developmental stages down. Starting with infants. An infant obviously doesn't know what a hospital is, so what is their primary stressor?
For older infants, like between 6 and 8 months, it is pure stranger anxiety. They have developed the cognitive ability to recognize their primary caregivers, which means they suddenly recognize when someone is not their caregiver.
Right, so you, the nurse, are the stressor.
I was reading the section on toddlers, and it blew my mind how much they freak out over taking a temperature or looking in their ears.
It seems completely disproportionate.
Totally disproportionate to the actual physical discomfort. Why does a plastic thermometer feel like an attack to a 2-year-old?
Because toddlers have a very poorly developed sense of body image and physical boundaries. They don't really understand where their body ends and the rest of the world begins. So any type of boundary intrusion, even something entirely painless like placing a stethoscope on their chest, feels like a massive existential violation of their physical self.
Wow. Then we get to the preschoolers. And this is where cognitive development introduces some wild concepts. Preschoolers are incredibly egocentric and rely heavily on magical thinking.
They do not understand scientific cause and effect.
Which means they connect entirely unrelated events.
Right. If a preschooler gets a respiratory infection and ends up in the hospital, they might literally believe it is a direct punishment.
Because they refuse to eat their vegetables.
Or because they hit their younger sibling the week before. They literally believe their bad thoughts or bad actions caused the illness.
That is so sad. And what about school-age children?
By the time they reach school age, they begin to understand the biological mechanisms. They know germs cause sickness.
Okay, so they're past the magical thinking.
Mostly. But their primary psychological fear shifts to a massive loss of control.
Because they're used to mastering their environment at school and at home.
Exactly. The hospital strips all that autonomy away. You tell them when to sleep, when to eat, when they get poked. They combat this by constantly seeking information as a way to mentally regain a sense of control.
Okay, so we have toddlers terrified of boundary intrusions, preschoolers paralyzed by magical guilt, and school-age kids suffering from a total loss of autonomy.
It's a lot.
How do nurses combat these deeply ingrained fears? The textbook leans incredibly heavily on therapeutic play, but what does that actually mean? Are nurses just supposed to sit down and be playmates?
It is so much more than recreation. Think of play as a clinical tool. Play is a child's native language.
Okay.
As a pediatric nurse, you have to learn to speak it to understand their hidden fears and help them process trauma. And you have to match the intervention to the type of play they naturally engage in at their age.
Right, because toddlers engage in parallel play, playing independently but sitting right next to other children. Preschoolers shift to associative play, where they might share crayons and interact, but there's no organized goal.
Yeah.
And school-age children move to team play, where they rely on strict rules and complex cooperation.
So therapeutic play takes advantage of this native language to achieve clinical goals. For a preschooler terrified of an IV insertion, you don't just explain it with words.
You give them a medical doll.
Yes, you give them a medical doll and actual safe medical supplies. You let them examine the doll.
It's giving them the power back.
Exactly. When a child acts out a medical procedure on a stuffed animal, they are physically lowering their own cortisol levels.
That's amazing.
They are taking an environment where they are entirely powerless and transforming it into a scenario where they have total mastery and control. It allows them to act out feelings of fear, anger, and hostility safely.
So you empower them with play, you manage their pain with precision, and you fight for their recovery. But pediatric nursing also requires facing the darkest outcomes. Which brings us to Chapter 11. Sometimes the focus has to change from curative treatment to end-of-life comfort.
Yes.
How do nurses navigate the heaviest chapter in the textbook, death and dying?
It requires immense emotional intelligence and clinical precision. The first critical distinction the text makes is between palliative care and hospice care, because they are entirely different frameworks.
Right. Palliative care is an interprofessional approach that focuses on managing manifestations and improving the overall quality of life when cures are no longer possible.
But a child on palliative care might still be receiving life-prolonging treatments.
Hospice care, however, specifically cares for the dying client.
Yes. When a patient enters hospice, the focus shifts entirely away from extending life. The sole objective becomes aggressive pain control, absolute comfort, and allowing the client to die with dignity.
And just like their understanding of illness, a child's concept of death is deeply tied to their developmental stage.
It is.
Infants and toddlers have no cognitive concept of death at all, but they are incredibly perceptive to the environment. They mirror their parents' emotions.
If the parents are exhibiting profound sadness, anxiety, and grief, the toddler will exhibit those exact same feelings, even if they have no idea why.
Preschoolers, with their magical thinking, are particularly vulnerable here. Because they lack a concrete concept of time, they often view dying as a temporary state.
They might think of it like going to sleep. Or they might believe that a person who has died still breathes and eats underground.
And tragically, their egocentrism can lead to intense feelings of guilt, believing their own bad behavior caused their terminal illness.
It isn't until they reach school age, typically around 9 to 12 years old, that they begin to grasp an adult concept of death.
Understanding the finality of it, it's inevitable, irreversible, and universal to all living things.
Clinically, as the nurse managing those final hours, you must recognize and explain the physical manifestations of impending death to the family so they aren't terrified by what they are seeing.
Like what kind of manifestation?
Sensation decreases in the lower extremities first. The child might experience Cheyne-Stokes respirations,
Which is that abnormal breathing pattern characterized by deep, rapid breathing, followed by periods of complete apnea, right?
Exactly. The body will physically feel cool to the touch as circulation slows down, but the client might actually experience a sensation of intense heat.
And crucially, the text explicitly notes that hearing is the absolute last sense to be lost.
Which is why nurses must encourage families to keep talking to the child.
Keep sharing memories, singing to them, and offering verbal comfort right up until the very end.
Yes.
But that raises an incredibly difficult reality, the moment the child passes. The textbook provides very clear, almost sacred actions for supporting families in those immediate moments of grief. You don't just step back and leave the room.
No. You actively facilitate the beginning of their mourning process. The clinical protocols are very specific here. You allow the family to stay with the body for as long as they desire. There is no rush.
You meticulously remove all the tubes, IVs, and medical equipment.
So the child looks like themselves again, not like a medical patient. You offer the parents the chance to rock the infant or lay in the bed with the older child.
And vitally, you always refer to the client by their name. You never refer to them as the body.
Never. You are honoring the child's life and the family's profound loss.
But taking on that role, absorbing that level of grief day in and day out, the toll it takes on the provider is immense. I really want to highlight the textbook's specific call-out for self-care for nurses at the very end of this section.
It is arguably the most important clinical skill in the entire book. Empathy is a powerful tool, but it requires strict boundaries and self-maintenance to sustain over a long career.
You cannot pour from an empty cup. Maintaining your own personal health, attending debriefing sessions, and explicitly expressing your own feelings of loss are required.
They are not just suggestions for when you have free time.
If you don't actively process your own grief, you will burn out. And you cannot be an effective nurse for the very next family who desperately needs you.
It's moving from the rational, transactional nature of adult care into the deeply relational, developmental, and emotionally demanding world of pediatrics.
Exactly. You're trading that cooperative adult for a complex, rapidly developing mind that needs you to translate the medical world into a language they can understand.
Well said.
So let's bring this all together. Mastering these chapters for your ATI Proctored exam is really about seeing the pediatric patient holistically.
It's knowing the anatomical angle to pull a toddler's ear for medication.
It's understanding the precise mechanism of a sucrose pacifier.
It's recognizing the clinical danger of a quiet child in the despair stage of separation anxiety.
And it's possessing the profound emotional grace required to remove an IV line so a mother can rock her baby one last time. Before you head back to your study guides, I want to leave you with a final thought to mull over. Consider how your own unexamined personal beliefs about childhood, resilience, and mortality might unconsciously affect the way you interact with these patients.
That's a great point.
Do you assume a child who isn't crying isn't in pain? Do you feel uncomfortable talking about death with a grieving parent, causing you to avoid their room?
True mastery of pediatric nursing requires not just knowing the textbook inside and out.
It requires knowing your own biases. Best of luck on your ATI Proctored exam.